Hi, and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we come to you every Wednesday as veterinarians and technicians in general practice to get you to the point where you are the best you can be in general practice dentistry. The episodes, we're going to be transitioning to pain management, and we're honored to have Dr. Mark Epstein, veterinary pain management expert, medical director at Total Bond Veterinary Hospitals in North Carolina, and a certified veterinary pain practitioner to join us here. He's a diplomat and past president of the American Board of Veterinary Practitioners and a past president of the International Veterinary Academy of Pain Management. Dr. Epstein also co-chaired the AHA and AAFP pain management guidelines, led the AHA Senior Care Guidelines Task Force, and was awarded the 2022 Vitica Small Animal Educator of the Year Award at the Western Veterinary Conference. Dr. Epstein recorded these in a live workshop back in 2023, so they're all very recent. All 5 episodes are categorized based on the agent. They are brief for a reason because there's a lot of information in each one. So please sit back and enjoy Dr. Mark Epstein.
I do want to cover some data about a new potential tool in the toolbox. This is an opioid antagonist, naltrexone. You're familiar with naloxone that's given to first responders to reverse opioid overdose. Well, this is naltrexone. It's an oral product that's labeled in people for alcohol abuse and for obsessive compulsive disorder. The idea about kind of downregulating the opioid to dopamine response that kind of promotes those behaviors. And it's used in dogs for obsessive compulsive disorders like tail chasing and things like that. Well, when it comes to using it for pain, there is an interesting twist to the tail. When you use it in a low dose, that for certain chronic pain conditions, there's on balance seems to be pretty strong evidence that it can be effective. When I say low dose, it goes like this. It comes as a 25 and a 50 milligram tablet. And those are the doses that are used in people for their indicated uses, alcohol abuse and for obsessive compulsive stuff. When you lower the dose to levels for pain, it's so small that even for people, it has to be compounded. So it'll look a little bit like this. So in people, it's like 1 to 4.5 milligrams per person, not per kilogram, per person. And if you take an average person size of 180 pounds, that ends up being about 0.01 to 0.05 mg per kg, which means like a 70-pound dog would get roughly a milligram, something like that. So you would have to get it compounded. Now, how would it do this? Well, it's hypothesized 2 ways. There are 2 enantiomers. One is the L in naltrexone, and it will bind up and antagonize just enough of your mu receptors to cause a positive feedback to say the body to say, I need to make more endorphins, more enkephalins. All right. So you get these more endogenous opioids produced, flooding the body when it sees a little bit of binding. So that is one through an upregulation of endogenous opioid production. The D-naltrexone, you can see here, kind of antagonizes the neuroinflammatory cytokines, which reduces inflammation and may actually downregulate these oncogenes, which means that you end up maybe having an anti-tumor effect as well, right? All those effects are lost when you give higher doses. So what's the data? We have 1 in dogs here using it in these dogs with mammary carcinoma. And the upshot is these dogs not only felt better, the dogs getting the low dose naltrexone not only felt better, they lived longer. So pretty interesting shot across the bow. You have to get this compounded. Have I used this? I have, particularly in some of the cancer conditions like osteosarcoma, other kinds of palliative effects. A little less with osteoarthritis and things like that, but it's not that I wouldn't pull this tool out if I felt like I needed to. We're going to go ahead and cover cannabinoids a little bit. I'm not going to go into all the mechanics of it, except to say, you have an endocannabinoid system. That means there's probably things happening with that as in terms of pain control. And the data behind it with osteoarthritis is really quite mixed. And it's important for me to point this out. Everybody got very excited about this Gamble study here, but there was um, some methodology issues with it. And the one I put here, just to kind of get you to be thinking a little bit, is that under normal circumstances, with almost any study looking at a pain therapeutic for dogs, there's going to be a caregiver placebo effect of about 40, maybe even as high as 50%, which means that half the dogs getting placebo were perceived as improving, either by the veterinarian and or by the owner. And in this case, with the Gamble study, there just wasn't a big caregiver placebo effect, nothing like what is seen in almost every other kind of pain study that is done in dogs with OA. So when that happens, when you lose the caregiver placebo effect, what does that mean? It means that somehow, probably it means that probably again, that the blinding was lost, that the observers could kind of pick up or knew or suspected who was getting which, who was getting placebo and who was not. And that kind of had informed inherent bias about how to score their patients. I'm not saying it was nefarious. I'm just saying that it's something that kind of goes on subconsciously and implicitly, not explicitly. So, for example, when it came to CBD, a hypothesis about it is that the observers could smell it. They could tell which dogs were on it just by the odor of their breath, and therefore a bias entered and caused the caregiver placebo effect to go down, which of course could make it look falsely effective compared to placebo. Well, the best study that we have is actually the Mejia study on the bottom here, much better designed study, and it showed no difference between the placebo and the CBD product that was used in that study. So now I'm going to share with you kind of a very, very high level look and dive into cannabinoids and actually all kinds of cannabis products. So THC and straight marijuana and whatever by the International Association for the Study of Pain. Now, these people are the world's leading experts in pain. And so they know more than anybody about everything about pain. And they conducted a comprehensive analysis just a couple years ago, looking at 4 different topics, the basic science and evidence about cannabinoids, then the evidence for clinical efficacy, and then the risk of harm. So with those, I'm going to go ahead and give you the outcomes of each of these studies and the final consensus guideline or consensus statement that came out of this really enormous, comprehensive look at it. This was all published about 2 years ago. And this basically is looking at the science of it, saying, yeah, okay, there are endocannabinoids. They do good things, or they probably have a pain modifying effect on patients. Okay, there's something to it, something to the science of it, and something to the physiologic effect of the endocannabinoid system. All right, so let's move on. This was a systematic review of the trials. And you know what? I mean, look at that. There was like 8,700 of them that were looked at. But at the end of the day, kind of take a look at, what happened. There were only 31 of the studies that were really high enough quality to pay attention to. And that's like unbelievable. And so here's what ends up being the study. I beg your pardon here. I need to get rid of a thing that just popped up here. There we go. And at the end of the day, looking at those 31 studies that were interpretable, basically, didn't support, didn't refute that the use of cannabis or cannabinoid products were effective for pain. This was a systematic review of systematic reviews. I mean, nothing is more comprehensive than it. And once again, they couldn't support or refute whether or not there were a pain modifying effect to any kind of cannabis product. And it's really because of the heterogeneity of these studies, of the quality control of these studies, methodology of these studies, just not able to draw conclusions. And now this is looking at potential harm of cannabis and cannabinoid products. And it says there can be. That's all it says. It says that it's possible. And that has to be elucidated. That has to be, conveyed to anybody that's looking to use these products. This was their final recommendation. I'll let you read it in red. They just were kind of a hard no at the moment. And I can tell you that since 2021, while there's additional data that comes out, it's equally problematic in terms of heterogeneity of the studies and the quality control of the studies and methodology of the studies. And the needle has not moved. So this is still, insofar as I understand, where the IASP finds itself, and much more needs to be done. If there's a piece of good news, is that and here in the U.S., there's a effort to change uh, uh, marijuana and other cannabis products from a Schedule One compound down to a Schedule 3, which will make it much easier to study. And we'll find probably much more robust data coming out. Well, if that were to happen federally, much more robust data coming out in the coming years. Then we'll have a much better conclusion to draw. So I think I mentioned this in one of the Q&A sessions, but there's an enormous problem with quality control, both in terms of having sufficient product in the bottle or having too much, containing potential toxic materials, and even having THC or the synthetic form of which is called spice. Now, I do think that there are veterinary companies that have kind of cracked the code, and there are a couple of veterinary companies you can trust, at least two. Um, but when your clients are getting it randomly off the internet or at a store nearby or something like that, then they have no way of knowing really what's in that, since there's no regulation, no regulatory analysis of it. And it will increase liver enzymes in people and in dogs, potential others. And then when it comes to drug interactions, we have no idea. This is like a complete Wild West in terms of what it does in connection with other therapeutics that are used. So this is where I find myself. These are the bullet points I've just kind of shared. So I'm not quite on the bandwagon. I will tell you that in North Carolina, where I am, I can't prescribe it anyway. I'm not permitted here. But even if it were, I'm not ready to make robust use of it. There are people that are kind of true believers, and I get it. And they may be right, and I may change my mind in a year or two or three. I don't know. If you want to follow the discussion, that's where to follow it. These are two different kind of groups of people with some overlap that follow the evidence as it begins to emerge.
For those of you who are listening to this on the podcast and not watching it on Facebook, Dr. Epstein mentioned two resources to learn more about cannabinoids. One is veterinarycannabis.org, and the other is a Facebook group called the Veterinary Cannabis Academy. I really hope you enjoyed that episode. If you are a veterinarian and you want to be one of the best in dentistry in general practice and take your team to that level as well, the Veterinary Dental Practitioner Program can get you there. Please visit ivdi.org and put in an application today. And hopefully we'll see you soon in the future in our meetings and in our virtual extraction wet labs. We'll see you next week.